Hello and welcome, everyone. I'm Shelley Gunther, Clinical Marketing Manager here at Clarius. Thanks so much for joining us for today's live webinar titled Practical Small Animal Ultrasound, Guiding Diagnosis and Management of Liver and Gallbladder Disease. Backed by popular demand, Dr. Camilla Edwards will be joining us in just a moment. In this webinar, Dr. Edwards, along with her incredibly patient dog Pippi, will demonstrate her systematic hands-on approach techniques for scanning the liver and gallbladder, as well as a detection, diagnosis, and management of a variety of diseases in cats and dogs, all using wireless ultrasound. A big thank you to the Vet Show and NAVC for inviting many of you to join us. You're among just over 3,100 veterinary medical practitioners who registered for today's popular event. Now, this webinar is RACE approved thanks to the Vet Show, so please do stay for the full session to qualify for 1 CE CPD credit. By participating for 50 minutes or longer, you'll receive an email from the Vet Show in the coming week to redeem your educational credit. After Dr. Camilla's presentation, I'll be performing some live scanning on my dog Mabel, who isn't quite as cooperative as Pippi, but she's getting there. And at any time during this session, you can use the Q&A box. We'll have a live question and answer session with Dr. Edwards following the presentation and the live scanning demo. Now, let me introduce you to our host for today's event. Dr. Oran Frankel is trained in emergency medicine in California. A passionate POCUS educator, Dr. Frankel has been using point-of-care ultrasound his entire career. He practices in a very busy academic teaching hospital in Vancouver as an emergency physician, and he serves as chairman of our medical advisory board. Hello, Dr. Frankel.
Hi, Shelley. Thanks for having me. And it's good to be here as always. I'm going to just jump right in and help set the stage for our discussion. Today's topic is more around hepatobiliary applications, and we'll admit the literature was not as robust as in other applications. And so we came up with a couple articles to set the stage. One was interesting about the finding of the prevalence of gallbladder sludge, and that there's associated abnormalities, particularly in cats, around gallbladder wall thickening. And so that the finding of sludge is not uncommon, but non-specific finding. And so it's unclear. It's thought to represent clinical pathology, but how important and how effective it is not entirely elucidated yet and requires further research. And maybe we'll get some of that today in the webinar. One area, though, in hepatobiliary ultrasound that is more characterized is around hepatobiliary neoplasia. And this review article really highlights how, as in other applications that we've discussed, ultrasound imaging can be incredibly useful to help characterize the nature of the lesions with particular characteristics that they may have, to help primarily differentiate primary versus secondary, or otherwise called metastatic lesions, from dogs or cats. And it can also help guide the FNA sampling to help further differentiate those diagnoses, which can really help shape management, as you all know. So before we jump into the deeper topic of today's conversation and more on the how-tos, we wanted to put up a quick poll. We know there are people from all over the world at various applications, and this is just a broad stroke question of where do you see the key advantages of using ultrasound? Is this something that you use and diagnose your patients on their first visit, or do you find it has improved diagnostic accuracy? Do you change your referral pattern, or are you new to ultrasound and maybe don't use it yet? So we will keep that open for another second, then maybe just close it out here. I'm curious to see where people are. Good. So only 10% don't use ultrasound. That's excellent. And then everyone kind of sees across the board, but really everyone around diagnostic accuracy seems to be where people are focused today, which is great because we are so happy to always bring back Dr. Camilla Edwards, who is passionate, as many of you already know, about first opinion level small animal veterinary ultrasound. She travels with her dog Pippi as a peripatetic veterinary ultrasonographer. Camilla teaches ultrasound in multiple organizations and has built a thriving Facebook community for first opinion small animal vets that I'm sure many of you are already a part of. And through her website, FOVU, she reviews ultrasound machines with general practice small animal vets in mind, as well as provides a host of other useful information and some of the topic that she'll be relating today. Dr. Edwards, I'm going to hand it over to you.
Thank you so much, Oren. It is a delight to be back and presenting another webinar for Clarius. I have to just say that I'm receiving an honorarium for this lecture, but otherwise I have no conflicts of interest. So today we're going to be really focusing on practical small animal ultrasound, as always, and how we can use it to guide diagnosis and management of liver and gallbladder disease. And ultrasound is really useful for guiding and being part of getting towards a diagnosis. But as Oren mentioned, it's not always going to give us the definitive diagnosis, but it is an important step along the way in getting there. Okay, so I wanted to give you a special show up gift for coming tonight. So especially those of you in England who might be more interested in the football match that's going on this evening. So if you, after this, want to pop over to fovu.co.uk/Clarius, I will give you a special thank you gift for showing up tonight. So let's have a talk about normal liver and gallbladder, what we're expecting to see on ultrasound. And we're really, when we're looking at liver, we are focusing on the parenchyma, we're focusing on the hepatic and the portal veins, and we're focusing on if we can see intrahepatic bile ducts. We wouldn't normally expect to see them, but if they are dilated, then we will be able to see them, and that's an important thing to look out for. So when it comes to the liver itself, thinking about the size of the liver, so there are no measurements that we can take that provide us with a reference range for the size of the liver, but the things that we look out for, which give us clues as to the size of the liver, include whether the liver extends caudal to the costal arch. So it should be cranial to that, and if we're extending further caudal than that, then that may be an indicator that the liver is enlarged. We are expecting nice pointed edges to the lobes as well. That's something to be looking out for. Hepatic veins are anechoic tubes within the parenchyma, and portal veins also anechoic tubes, but they have hyperechoic walls. So that's how you can tell those two apart. When it comes to the gallbladder, we're really thinking about the wall, so the thickness of the wall. Can we see different wall layering going on? We're expecting a very, very thin wall. We try and follow the common bile duct if we can. That's easier done from the right hand side, but in a normal patient is very tricky to follow. And then we're really interested in that lumen content. Just like in that article that Oren highlighted, our thoughts have changed a bit about lumen content, and certainly with dogs for a long time we've known that some sludge can be normal, but with cats, because of that article, we've become a bit more aware that actually sludge in cat gallbladder lumens can also be incidental. So what abnormalities are we looking for in these organs? So when it comes to the liver, we talked about size. We can judge if it's hepatomegaly by if the liver extends beyond the costal arch, if the lobes are rounded rather than pointed. Smaller livers are harder to judge, and it's much more subjective. You'll get a feel after you scan lots of livers what is normal and what is not. And when it comes to the gallbladder, it's all about when did the patient last eat. If we have a patient that has just eaten before we scan, we're expecting the gallbladder to have been emptied and to be much smaller. If it's been a long while since the animal ate, then the gallbladder we would expect to be larger. So thinking about whether that fits in with the clinical picture we're seeing. When it comes to echogenicity, we are expecting the liver to be sort of in the middle of the range that we get in echogenicity in the abdomen. There's a useful mnemonic, which is "My cat loves sunny places." The M standing for medulla of the kidney, C for cortex of the kidney, L for liver, S for spleen, and P for prostate. And that's going from hypoechoic, so dark, to bright hyperechoic along that scale. So liver falls somewhere in the middle there. And the liver may be more hypoechoic than we're expecting. That's quite typical in steroid hepatopathies, or if there's lipid infiltration. So particularly in hepatic lipidosis in cats, we might see that. Or it might be generally hypoechoic, and we often see that and can judge that when the portal veins with their bright hyperechoic walls stand out a bit more. So that can help us to judge whether the liver is hypoechoic or not. Then we might see mixed echogenicity or lesions within the liver. And when it comes to the gallbladder, thinking about the echogenicity of the content, it should be nicely anechoic. It should cast an acoustic enhancement beneath it as the sound waves pass through the fluid contained in the lumen of the gallbladder. But if we are seeing sludge, we need to characterize that. And we're really thinking about, does it move? How quickly does it move? If it's not moving, does it have flow within it and it's actually soft tissue, or is it something else? Thinking about the margins, particularly with the liver, we're expecting that to be nice and pointed edges, really smooth, but we might see irregularities on the edges there. When it's the gallbladder, we're thinking about the wall. We can see things like the halo effect, where we might have a darker ring around the gallbladder, and this can be indicative of cholecystitis, right-sided heart failure, anaphylaxis, or hypoproteinemia. So quite a broad range of things that can show up, but really those four things, if you see the halo sign in the gallbladder, are to think about. And then using Doppler when you're assessing particularly the liver, because those anechoic tubes you see in the liver, you want to be sure are actually blood flowing rather than bile ducts where you won't see any flow, and you might you might mistake them for blood vessels, the bile ducts, but it's really important to not miss if you are seeing dilated bile ducts. Okay, so first of all, we're going to move on to the liver, and we're going to look at how to practically scan the liver, and then we're going to have a look at a case which involves the liver. Okay, so I'm here with my dog Pippi. Her head is towards the camera and her tail is away from the camera. She's in right lateral recumbency. So I'm working here to make sure that I get my cranial view in, and I'm fanning through in this longitudinal view. So it's really important, and one of the hard things to do with the liver is getting the whole liver visualized. So one of the things that we want to do, so that here in transverse, we want to make sure that the diaphragm, which is this bright hyperechoic line that we see. So here we're in longitudinal again. So this hyperechoic line is all on the screen, all the way down to the bottom, and that we're seeing it up to the top as well. So then we've got our whole cranial aspect. Here I'm actually getting the caudal aspect of 2, but often I will break this into 2 sections. So do a cranial portion of the liver and a caudal portion of the liver. And I want to be fanning all the way through to the extremities. Then I'm rotating the probe to get a transverse view, and then I'm fanning all the way cranially and all the way caudally. And each time I fan until the organ completely disappears. This first case was a ragdoll, a 16-year-old female neutered ragdoll with a history of weight loss. So here we're looking at the liver. We've got this bright hyperechoic diaphragm line here, and this is some normal parenchyma with a large lesion seen within the liver. So here's that lesion. As we're fanning through, here's another lesion. So we've got a couple of lesions. I'm putting colour flow mapping on to try and understand whether there's a lot of flow or a little bit of flow in that lesion there. Okay, so so here we're scanning through in a longitudinal view. We can see the diaphragm going up on this left-hand side. We can see the gallbladder coming into view also, and these two large lesions. And then we are rotating the probe to get a more transverse view where we've got the diaphragm a bit more horizontal, and we can see these hyperechoic lesions, quite large, and they've got these cystic regions within them. So they've got anechoic or dark black areas, and potentially some acoustic enhancement beneath them, suggesting that they will be cystic with fluid within. So it's always important to really characterize your lesions. Owners won't always want follow-up or more investigations, but the more information we have on, for example, the size of the lesion, so taking measurements, trying to figure out length and width, looking at flow, counting how many lesions there are, because when we follow up on these cases a little bit later on, if the owners don't want sampling, then at least we've got something to see whether things are improving or getting worse if we do trials of treatment, for example. So in this case, the owners didn't want further workup, and this is quite tricky with hepatic lesions because although ultrasound is really sensitive at picking up lesions and spotting even very small lesions, it is not so good at differentiating between them. In this case, we suspected primary neoplasia. We didn't find any other abnormalities in the abdomen. So we're really thinking about hepatocellular adenoma or carcinoma or biliary cyst adenoma, and this is quite common in cats. So secondary spread seemed much less likely and is less common in cats than a primary neoplasia in the liver. So we were suggesting sampling, but the owners unfortunately did not opt for that. So let's talk a little bit about ultrasound-guided sampling and how that can help. So first of all, we're going to look at practically how to do ultrasound-guided sampling, and then we'll have a look at a case, a liver case, where that really helped and made a difference. So here I'm using this phantom, this pink phantom you can see. I've got gel on the phantom because it doesn't work very well, the connection, unless I'm using gel, but I would never use gel on a patient when I'm taking samples, because I really don't want contamination with the cells with the gel, because the gel will cause the cells to explode. Pathologists get very grumpy with you if you leave some gel with the cells on the slides. So what I would do with a patient is I clean away any of the gel from the sampling, and I will use alcohol or spirit as my coupling agent for the sound waves to pass in. The next thing I would do is check up in this top region by my marker on my probe for any blood flow in this region, and also any other organs that might be in the region. So really fanning through that area, being sure that my needle through that area is not going to pass through any other organs or any major blood vessels. I'm then going to measure from this top corner down to into my lesion to measure that distance, because that's going to tell me what length needle I need. And then here you can see I'm letting the needle enter on the side of the probe that has the light on it. So here we've got the light here, so that corresponds to our marker, and I'm placing the needle just in front of that. And with experience, you'll know what angle you need to hit the depth that you need, but that comes with practice. So I really encourage people to practice. You can use meat or tofu or jello. There's lots of things out there, or get a phantom like this and really practice so you can follow that needle all the way down to the lesion. Once I've hit the lesion, I'm using a woodpecker technique to move the needle backwards and forwards, and then I'm watching the needle withdraw as well. I'm going to put that sample onto a slide and make a squash preparation ready for that. Okay, so case number 2 was a 16-year-old female neutered terrier. She had a history of increased urination at night and increased liver markers, pretty vague history there. One of our only findings on ultrasound was this incredibly large lesion in the liver. So we can see the diaphragm here, we can see the gallbladder, and then this lesion here. And it looks quite similar to the lesion that we saw in the cat, but it's most likely going to be something different. And this is where characterizing lesions on ultrasound doesn't necessarily give us the definitive diagnosis. So this lesion is hyperechoic, but it's got these cystic regions within it. And then we can see in a transverse view, so we've got our diaphragm more horizontal, we've got normal parenchyma over on the left-hand side of our image. I know that's the right-hand side of the dog because we can see the gallbladder on that side just here. And then we can see this lesion that's taking up over half of the liver there. So this, we took a fine needle aspirate in this case, and this revealed cells which were suspicious of hepatocellular carcinoma. And with this, liver lobectomy is actually the treatment of choice. So this is quite an effective treatment, but it's quite a large region of the liver that would need to be removed in this case. But it gives the owner the options. They know much more about what they're letting themselves in for when they go for a surgery, if they've got that extra information there. Okay, let's move on to the gallbladder. So with the gallbladder, we are going to look at how to scan the gallbladder, and then we're going to look at a couple of different cases of some of the most common things that I see in first opinion practice when it comes to scanning gallbladders. So when I'm scanning gallbladders, I prefer to do this from the right-hand side. This is where we're going to be able to see the common bile duct going up towards the duodenum if it's visible. So in here we've got Pippi's head towards the left and her tail over towards the right. And I've got the probe angled quite cranial. So I'm coming behind the xiphisternum. One of the things that can really irritate the animals when you're scanning liver and gallbladder is if you push the probe onto the ribs or onto the xiphisternum too much. So I much prefer to push the probe in towards the abdomen. So here we're pushing in this way to get behind the xiphisternum rather than trying to force cranially, because they find that really uncomfortable. So here I'm angling the probe quite cranially, but also up towards the right-hand side of the body. We can see the diaphragm, and importantly here, I'm not that worried about keeping the whole of the diaphragm in the image because I'm not concerned about looking at the liver. In this view, I've looked at the liver when the dog was in right lateral recumbency. Now that it's in left lateral recumbency, I'm more focused on the gallbladder. Here we can see Pippi's got quite a small gallbladder. We can see by the stomach that she's recently eaten, and that's hence why there's a small gallbladder. But we can see that even as a small gallbladder, it's got a very thin wall there, and that the luminal content is anechoic, so a normal gallbladder. So that brings us on to our first gallbladder case. So this was a male neutered 8-year-old cockapoo with a history of raised liver values on bloods. So this was what we were presented with when we were scanning. We can see the hyperechoic diaphragm down here. We can see the liver parenchyma in here, and we can see the gallbladder. So there is some anechoic content in there, and there's certainly some acoustic enhancement below it, which tells us there is some fluid in here. But there is also some content, some hyperechoic content within this gallbladder. So we are first of all just scanning this gallbladder while we're scanning the liver, and just taking note of what's going on. So this will be when the animal has just been laid in right lateral recumbency, clipped up, and then we're scanning this as one of the first organs that we come across. But again, in that time, I would normally expect any normal sludge to have settled quite nicely onto one side, onto the gravity-dependent side of the gallbladder. But here we can see that there is some content that is away from the edge. We've got anechoic regions here between the sludge and the wall. So now I'm focusing much more on the gallbladder. I'm not worried about keeping that diaphragm in my image. I'm optimizing the image to get the best view of the gallbladder. And we can see that there's a bit of a stellate pattern where this sludge is hanging onto the wall, but in strands, and it's got a sludge that's suspended in the middle of the gallbladder. Here we can see we're following down towards the common bile duct as well. So as we fan through there, we can see down towards the common bile duct. So here again, focusing more on the gallbladder itself rather than the liver parenchyma, we can see this gallbladder with some anechoic fluid and some sludge that's suspended in the center. And turning the animal over is really key. So because I scan the liver when the animal is in right lateral recumbency, and I can get an overview of what's going on in the gallbladder there, and then I repeat the gallbladder examination when I've turned the animal over as soon as I possibly can. So any sludge that's moved, I can get an idea of how long it's taking to settle. These were some still images that we took, and we can really see that stellate pattern where the sludge is, or the mucus is suspended in the middle of the gallbladder with these strands reaching out to the gallbladder wall. And here we have got a mucocele. So in this case, the dog underwent a successful cholecystectomy and went on to be very happy and normal after that. Often mucoceles, we find them in older patients, often with comorbidities. So we often see it with hypoadrenocorticism, and once we're getting lots of comorbidities, then owners are sometimes more reluctant to go for a big surgery like a cholecystectomy. In this case, we had no other illnesses going on, so the owners were quite happy to go for this surgery, and it was successful. So case number 4 was a 9-year-old female neutered Schnauzer with a history of polydipsia, raised alk phos, and bile acids, which was picked up on a pre-general anaesthetic dental bloods. And this is quite a common thing that the owners will put things down to age, the animal's slowing up, no real specific symptoms, but then when you're doing bloods, typically for a general anaesthetic for doing a dental, you'll pick up on some abnormalities, either showing liver or gallbladder issues. And this is what we found when we were scanning the gallbladder. So we've got the diaphragm up here, and we've got this gallbladder. And we can see this content in the gallbladder is quite mixed echogenicity. So normally if we have incidental sludge, it's generally quite homogeneous but hyperechoic. Here we've got some regions that are anechoic, and lots that's hyperechoic. So we're really trying to judge here how mobile is this sludge? Are we talking about mucocele, for example? We haven't quite got the same stellate pattern as we did before, where we get those strands coming off the edge and a mucus held centrally within the gallbladder. So we're not quite seeing that, but we're also not seeing it settle very quickly to the gravity dependent side either. It doesn't look like soft tissue. It doesn't look like it's particularly adhered to the gallbladder walls necessarily. Here we can see after a long period of time, it has started to settle to one side here. And it's really important to know where, when you're scanning, where is up, where is down. So is your light pointing down towards the table? Well, this would be a bit odd if that was the case here, because it seems to be settling over on this side. But it's really important to be aware of that when you're scanning. Okay, so here we've got our gallbladder again, and we can really see how heterogeneous it is. It does appear to be settling, but very, very slowly. And this can often be the beginnings or the beginnings of a mucocele. When the sludge starts to slow down, it's starting to become more mucoid, starting to get more firm. But we can see some movement, and particularly here in this image, we can see with the breath that actually that sludge is mobile. There is some movement within that sludge, and it is eventually settling, but very, very slowly. So we're quite concerned that this might develop into a mucocele in this case. Again, we can see how heterogeneous this is over here, and it's got this large anechoic area within it. So the sludge in the gallbladder was extremely slow moving. It was really heterogeneous, and we'd normally expect with sludge that we find that's incidental that it is quite homogeneous and quite hyperechoic. We saw a mildly thickened gallbladder wall as well, and this persistently raised ALKP. And so it really is a case of putting everything together to get this diagnosis of cholecystitis. And we were worried about this progression, that this sludge was really slowing down in its movement, and that it might progress to becoming a mucocele. So in this case, we used ursodeoxycholic acid to get that bile moving more effectively. There was no evidence of an obstruction here, which would be a contraindication for using that. We recommended monthly ultrasound examinations, and the owner was very good at sticking to that. So we repeated ultrasound scans regularly, and the sludge didn't really improve. In fact, initially it started to look a bit worse. We discussed taking a aspirate sample of the gallbladder content, but there are potential risks with that, and if we have a bile leakage, that can be very serious. And having discussed that with the owners, they decided not to go down that route. But that is often very useful for culture and sensitivity and getting that information. So we trialed antibiotics, and they were extremely effective in this case. And we continued to monitor for quite a few months. And this was where the point where we got to most recently. So this we can see this is just after clipping. So the dog has not been lying in lateral recumbency for very long, and we can already see that the sludge has really settled very quickly. It's looking much more hyperechoic, more homogeneous there, a real big improvement in that sludge there. So there we go, we're fanning all the way through. It's always good with organs and lesions, etc., to try and fan through in multiple planes.
It's markedly different, the repeat.
It's markedly different. It took us quite a lot of months to get to this stage, but also the interesting thing was that the owners reported that the dog was feeling much better. In fact, straight away after a few weeks, the first time I rescanned it, even though the images didn't look much better, the owner reported that the dog had got a new lease of life. So I often wonder in these cases where just that slow progression of disease, people put it down to old age, slowing up, rather than actually there are some symptoms here. So yeah, markedly improved. And just that reminder to actually figure out what is down and what is up. So here the light on my probe was pointing down towards the table, and there we can see that straight line of this sludge having fallen to the dependent side. And just within that time of clipping and trying to get the probe on as quickly as possible, that was enough time for the sludge to settle, which is fine for incidental sludge. That would be absolutely normal. So this sludge in the gallbladder was now moving normally, was much more homogeneous, and we sort of wait and see whether the dog can do well, perhaps off ursodeoxycholic acid, or whether he needs to be on that longer term. But certainly a great improvement in both the dog's condition, but also what we were seeing on the ultrasound images. So what are the take-home messages today? So as always, performing that systematic exam. So really thinking, particularly with the liver, the challenges are getting the entire liver in your image. One of the hardest things to do is get that cranial part of the liver in your image. So really following that diaphragm all the way up to the top of your image, so you're not losing a bit off to the left of your image, and making sure you've got enough depth on so that you can see the diaphragm curving round at the bottom of your image also. So making sure that you've got the entire liver on your screen and nothing's falling off the edges, and then fanning all the way through. If you can't do that in longitudinal, then taking it in two sections, in a cranial section and in a caudal section, is the way to do that. And then rotating the probe to get that transverse view of the liver, and fanning all the way through that. Again, if you can't fit the whole liver in transverse on your image, taking in a left side and a right side of that liver can be really useful. When it comes to the gallbladder, optimizing your image for the gallbladder. So don't worry then about having the diaphragm in your image. Decrease your depth so that you're really focused on that gallbladder. And again, trying to look at that in a couple of planes also. When it comes to any lesions that we see, really characterizing those, so taking measurements, assessing whether there is any Doppler flow through it, and that can be really useful, even if you can't take samples, if the owner's not willing to put their animal through taking samples or can't afford samples, then knowing those things, how many lesions there are, can be really helpful for a repeat ultrasound examination to see how things are progressing. When it comes to gallbladder, we're often most concerned about the sludge or luminal content in that gallbladder, and really thinking about how mobile is this sludge? And the only way to see how mobile it is by moving the dog. And that's one of the reasons I really like scanning in lateral recumbency. It's a question I often get asked, why I don't scan in dorsal, why I prefer lateral, and the gallbladder really sums it up for me. I get to see the gallbladder in 2 different positions on every patient, and I get to assess how quickly that content, that lumen content, settles down to the gravity dependent side, or if at all. With the mucocele, obviously we saw that it doesn't always settle. So taking measurements and assessing movement, really, really key. And then if you can, using ultrasound-guided sampling is incredibly useful. We saw that those lesions in the dog and the cat in the liver looked very, very similar, but they potentially are very different processes going on. And without getting that sampling, we're really not going to understand fully and have a definitive diagnosis there. Okay, so I just wanted to let you know about the courses that we run at FOVU. We now have 3 of them race accredited. So we have scanning the emergency patient, a great starting point because we really focus on answering one question, one specific question. So you don't need to know the whole of ultrasound, just do one question at a time. When it comes to the basics, we cover all the large organs of the abdomen. The trickier bits, we cover all the small bits, the lymph nodes, adrenal glands, blood vessels of the abdomen. And then we have a basic echocardiography course, which is great for general practice level knowledge. And we have a course for nurses and techs also. So you can find those courses at fovu.co.uk/ultrasound-courses. And then, yes, just as a thank you for watching, if you pop over to fovu.co.uk/Clarius, you can pick up a free FOVU abdominal ultrasound framework. So this is where we guide you through the different organs with reference ranges included on that. It's a really handy printout that you can have next to your ultrasound machine. We will also send you the FOVU Independent Clarius C7V HC3 review, and also as a thank you for coming tonight, a 10% discount off a FOVU course of your choice. Okay, thank you.
Great. Thanks so much for that excellent presentation, Camilla. Please keep using, I was just scrolling through the Q&A, it's full of amazing questions. And we are going to get to those very shortly. Please keep using that tab below to help orient us. Before we get to the Q&A, we're going to hand it back over to Shelley for a quick live demo.
Thank you so much, both of you. And I'm using the same.
It's hot.
It is so hot here. Using the same scanner that Dr. Edwards used. So this is the C7 VET scanner, and this is the light, the indicator. And when it's green, we're ready to go. So I'm just going to turn Mabel onto her side here and have a look at her liver. So let's roll you over, buddy. All right, good. I'm going to make sure she's on the camera here. Good. Now I'm just going to put some gel on the scanner. And I wasn't familiar with liver scanning on animals. And so I did find it a little bit tricky, and I know there were a couple of questions about orientation, you know, what's up and what's down. And what I will show you is, sorry, that gel's cold. You'd think it would be refreshing today. So the light on the scanner here corresponds to this indicator here. So I have the light pointing towards her head, and I'm just going to increase my gain here. And then when I angle down towards like more caudally, then that's going to be in the opposite direction of the light. And conversely, if we turn the scanner 90 degrees, now, if I was to turn the light toward the downside, that's kind of where we would look that would be the more dependent portion in the position that I have her in. So so I hope that that makes sense. Let me just go in here. And so what I'm doing is I'm just I have the scanner midline on Mabel, and I'm just kind of pushing and angling up towards her head. And I believe, Dr. Edwards, I have the liver.
You have the liver. You also have the spleen off to the right. So
So this is it here.
Absolutely, we can see spleen there, and then we can see liver. Yeah, so we can see that diaphragm,
which is right here.
Yeah.
Okay, and then I'm just.
And then we can also see something that we commonly see, but don't commonly talk about, is this darker area here, which is Mabel's falciform fat. So we're all.
Are you calling my dog fat?
No,
I'm kidding.
No, we're all familiar with it as vets. When we do surgery, when we do abdominal surgery, we often come across the falciform fat, but we don't often talk about it on ultrasound. So it's got quite coarse appearance, and it can sometimes be mistaken for liver itself.
It's very prominent.
It's quite prominent in Mabel. Yeah. So
all right.
And when you think about when you're doing surgery, that window that you're looking through is exactly where the falciform sits.
Right. Yeah.
And then you're looking in towards the liver there, and we can see Mabel's gallbladder also, which is very
right.
nice.
So here's her gallbladder coming in right here. So I'm just fanning through from her right and then down to her left to make sure that I'm including all of the liver and gallbladder. And then I will rotate my scanner 90 degrees. And now my light is corresponding to here. And so this is going to be her right side, and this would be her left side.
Yeah. And so now we can see that the diaphragm is a bit more horizontal. I'd probably increase my depth a little bit, just so that we don't lose any of that liver off the screen. So lovely.
Okay, so there's my diaphragm there.
And conventionally, we would put the gallbladder on the left-hand side of our image. So much like in X-ray and other diagnostic imaging, we would have the right-hand side of the body on the left-hand side of our image. And that's exactly what you've done here, Shelley. So great.
Good. So again, just fanning as far cranially as I can.
And so when we fan cranially, we'll almost feel like we fall off the Ziffy sternum. In fact, I quite encourage students when they're first learning to actually come off the Ziffy sternum, because the liver lies right up against the sternum. And so if we want to be sure that we've seen the whole thing, we really need to get down to the bone there. So
it's up much higher than I expect.
Yeah.
All right, great. Okay, and then there's the diaphragm again and gallbladder here. Good. I was going to ask you, do you ever scan the liver intercostally?
Absolutely, you can do that. Yes. So sometimes, particularly in large, deep-chested dogs, it can be really difficult to get to the liver because it's very far cranial. You really have to get behind the ribs, behind that Ziffy sternum to get far enough cranial. So sometimes there it can be really useful to look intercostally. The difficulty with looking intercostally are that we get these rib shadows.
Yes, which we're seeing right here.
Right here. That will block some of our image. It's also hard to know that we've really seen the whole of the liver to its extremities when we're looking intercostally. So I always try with the technique that I've described, but if I want to get a better view, then I might add in the intercostal approach.
Awesome. Excellent. Good girl, Mabel.
Well done, Mabel.
Yeah, Mabel.
All right. Good. That was fun. I swear, I learned so much from you, Camilla. It's so much fun.
And Mabel's getting better every
She
time we
totally is. I
Right.
rarely have to even tell her to roll over. So
Yeah.
yeah. All right. So just a friendly reminder to everyone to stay on. I think we're past the 50-minute mark here, but yeah, just to qualify for that CPD credit. And before we begin our live Q&A, we have a question for you. Now, this poll is an opportunity to learn more about our Clarius wireless ultrasound scanners. And so please complete the poll to let us know if we can provide further information about Clarius HD3 vet scanners, and click on as many options as apply. And while you take a minute to participate in the poll, I'll tell you a little bit more about the Clarius Vet HD3 scanners for the highest definition wireless ultrasound imaging for diagnosis, as well as procedural guidance like you saw today for small, medium, and large animals. Our C7 HD3 microconvex, which is the one I used with Mabel and the one that Dr. Edwards used with Pippi, is specifically designed for imaging in small and medium animals like cats and dogs. And we also have the C3 convex vet scanner for larger animals like sheep and horses, and the L7 linear vet for higher resolution animal MSK imaging, often used for equine applications. Our third generation family of vet scanners are unrivaled for high resolution imaging in handheld ultrasound and dedicated animal presets. Each scanner is designed to deliver the image quality and frame rates only found in traditional ultrasound systems, but at a fraction of the cost. So you're looking at about an 85% savings. Artificial intelligence replaces complex knobs and buttons to optimize imaging on the fly. This will streamline your workflows, making our scanners fast and easy to use, and easy to learn as well. Clarius is also wireless with zero footprint for ultimate portability to scan animals anywhere they are, from vet clinics to their homes to out in the field. You can get free movement with no wires getting in the way to startle the animals, also making it so much faster to clean and disinfect. The Clarius wireless scanners come with an ecosystem that includes a free app for your iOS or Android device with free updates. Available with our membership, Clarius Cloud is available to save and manage unlimited exams and create reports anywhere. Your membership includes in-app Clarius classroom videos with experts like Dr. Edwards, as well as onboarding with Clarius clinicians to build your ultrasound scanning skills. And Clarius Live delivers one-click telemedicine if you'd like to share live scanning with a colleague for a second opinion. With your membership, you get exclusive access to AI-powered features like voice controls, and you get popular advanced veterinary package that offers more flexibility with additional tools and advanced workflows for various animal exams. For example, with finely tuned presets by categorized by anatomy, and this will give you more comprehensive measurements as well, and needle enhanced for procedure guidance. The new OB growth tables are also included for both dogs and cats to obtain more accurate estimations of gestational and age and fetal growth. And with increased ultrasound billings, you'll see a rapid return on your affordable Clarius HD3 vet scanner. Now, we have a really exciting offer I'd like to tell you about. It might even sound too good to be true. So if you are interested in purchasing a Clarius vet scanner, you can upgrade your V1 Clarius, HD Clarius, or any competitive POCUS device and receive a substantial discount on a new HD3 scanner. Now, this offer is only around for a little while, so act fast and please reach out to your local Clarius representative. Now, let's begin our Q&A session. Use the Q&A icon in the menu bar at the bottom of the screen to ask questions for Dr. Edwards. And because this is a common question, I do want to let everyone know that in the coming days, we'll send you an email with the recording for today's webinar. And if you stayed on for at least 50 minutes, you'll receive an email with a link from the Vet Show to redeem your CE or CPD credit. I'd like to welcome back Dr. Frankel to moderate our Q&A session.
Yeah, let's jump in. So many questions. A lot of them are, I'm going to try and group them together. So the first one, this comes up a lot around scanning position, Camilla, like dorsal recumbency versus lateral. Can you speak to it? A lot of practitioners seem like they prefer doing dorsal recumbency is when the patient's on their back, right? The animal's on their back.
Yeah.
Can you talk about scanning on the back versus scanning on the side, when to do one or the other? Can you interchange?
Yeah, so I think a lot of it stems from what different countries, different universities teach. So it becomes sort of a cultural thing that Yeah, certainly I think in the US, they scan often in dorsal recumbency, and certain areas in Europe as well. So I spent quite a few months shadowing quite a few specialists, some who did dorsal recumbency, some who did lateral. And for me, the benefits of scanning in lateral just outweigh dorsal scanning. So culturally in the UK, it is more common that we scan in lateral recumbency, but the advantages I find that it has are that I have to sedate fewer patients because lateral recumbency is a much more natural position for an animal to lie in. It's a much easier position for nurses to restrain patients in, and certainly lots of owners in the UK are wary about sedation or general anaesthetic. So where we can avoid that, that seems to be a great thing. The other thing is what I discussed in this webinar is that we see movement. So if you scan the whole abdomen in dorsal recumbency and you don't move the animal, I feel like you're missing out on some information there. So I get an opportunity to look at the two major organs where it's important are the gallbladder and the urinary bladder, where we might have sludge and sediment. And I get to look at that when they're in right lateral recumbency, and then I can flip them over and I can judge how quickly is that moving, how quickly is it settling. That gives me vast amounts of information. But also if things are in the gastrointestinal tract, I can see if they are moving or if they're adhered to the gastrointestinal tract wall. So there's so much information that I get from scanning in lateral recumbency that I wouldn't get if I just scanned in dorsal recumbency.
Excellent. A lot of people want to know which antibiotics the dog got for the cholecystitis or the sludge.
So that was Sinulox or coamoxiclav. That's quite effective in gallbladder disease.
Oh, that's like basically what I give to adults. It's my drug for everything. Yeah. Okay, great. Excellent. Easy. Glad to hear that one crosses over species. People want to know about how do you tell if the duct is obstructed or if the biliary tract is obstructed, and or do you ever, do what would be a cystotomy or sampling the gallbladder, needling the gallbladder?
So definitely looking for obstruction. As often with pathology and looking for an ultrasound, things often become more obvious when there is pathology present. So a blocked bile duct dilates pretty quickly and effectively and becomes quite large and obvious. It can become quite tortuous. So you just see this large anechoic tube sort of snaking its way towards the obstruction. And yeah, if it's a complete obstruction, it becomes very, very obvious on ultrasound. So you just get whatever is inside, so usually anechoic content, which then dilates the common bile duct, and you can see that, or the intrahepatic bile ducts, and they become much more obvious. When it comes to sampling the gallbladder, so when I talk about when I was following those specialists, there were some of the specialists who really avoided taking gallbladder samples at all costs, and some that were happy to do them. So I, working more in general practice where we possibly don't have the same setup if something went wrong with a gallbladder sampling, don't do it very often, because when I put the risks to owners, they get quite worried about it. What I would say is going through the liver. So it's one of the only times I suggest going through another organ to get to an organ, but going through the liver to get to the gallbladder helps to create a seal when you remove the needle from the gallbladder. Not sampling if you're worried about gallbladder wall pathology, because it may be particularly friable. But there are studies out there that say, this is truly excellent for getting a really good culture and sensitivity, and bacteria are often involved in cholecystitis. So yeah, there are huge advantages, but there are also huge risks with it. So it's weighing that up in each individual case, really.
Great. I want to be respectful of everybody's time, and I don't think there's any way we're going to get through all of these questions. But most of them are thank yous, a lot of thank yous to you, Camilla. So we can just address those now. And then, yeah, we will be following up. Shelley, can you address that and how we're going to follow up?
Yeah. I'll email them. If you email me the questions, I will email them back.
Excellent. Yes, there was a lot. I was madly typing as we went too. So yeah, just a reminder that you will receive an email with a link to a live video, as well as a copy of the slides in a PDF format. So you'll get that in the coming days. So please complete our closing survey here just to give us your feedback so that we can continue to give you great educational content like today. I'd like to conclude by thanking Dr. Edwards once more, and also thanks Dr. Frankel and all of our furry supporting characters. And of course, thank you to all of you for joining us today. We hope to see you again soon in our next webinar. In the meantime, keep scanning.